Assalamu alaikum.
Sorry.
Hello, Dr. Nadir. Hello, everybody.
Hello.
Wa alaikum assalam. Hello, everyone.
You can go ahead.
Okay, thank you, Dr. Nadir, for giving us this opportunity. And I would like to thank my team to be willing and prepare these presentations on this, busy time of preparing for interviews. And I need also to thank everybody who's joining the meeting today. And today's meeting is prepared by TEL and TEL 1 team, and we had 5 agendas for today, but one of the agendas of colorectal CA was rescheduled by the presenter for possibly next week's. So we have 4 agendas for today, and I'll go ahead and invite my team to present the topic. The first one is physical psychological and financial abuse. That's going to be presented by Dr. Sakshi. Sorry if I'm pronouncing your name wrongly. And the second topic is sexual abuse and neglect. That will be presented by Dr. Aman. And the third part of the first topic is screening and intervention and prevention of abuse and neglect in elderly. That's going to be presented by Dr. Faaiza. And the second topic is AI in medical research. That's going to be presented by Dr. Mona Eshag. And the third topic is YouTube. That's going to be presented by Dr. Ali Gafoon. And the last topic is critical appraisal. That's going to be presented by Dr. Mohammad Emad. So for the sake of time, I'll go ahead and invite the first presenter, Dr. Sakshi, to present the topic. And thank you for this opportunity. Dr. Sakshi, you can go ahead.
Hello, everyone. Am I audible?
Yes.
Okay, let me just share my screen.
Hold on, let me.
Can you see my screen?
Yes.
Okay. Okay. Hello, everyone. I hope you're all doing well. I know this is a very anxious time of the interviews and everything. I'm happy to present today on this topic of elderly abuse, which is a very concerning topic going on around the globe. So let me start with the presentation. Just some quick facts. WHO describes elderly abuse as a single or repeated attack or lack of appropriate action occurring within any relationship where there is an expectation of trust which cause harm or distress to the old person. Around 1 in 6 people above the age of 60 years have experienced some form of abuse. And the rate of this abuse in elderly population has increased, especially during the COVID pandemic time. So going further into the types of elderly abuse, we have 5 main types. First is physical, second psychological, third one is financial, fourth is sexual abuse, and the last one is neglect. So multiple forms of this can occur at once as well. So I'm going to present on the first 3 types of the elderly abuse. So starting with the first one, physical abuse. A definition, it is an intentional use of physical force that results in injury, pain, or impairment. Some of its examples are hitting, slapping, pushing, misuse of restraints or medications, inappropriate handling, or any rough treatment. Some of the signs. So physical signs to look after are bruises, lacerations, or wells in different stages of healing, broken bones, sprains, dislocations, any signs of burns or abrasions. And some of the behavioral signs are fearfulness around the caregivers and unexplained injuries or some delayed medical care. So the risk factors for this type of elderly abuse, it is dependency on the caregiver or any cognitive decline or a caregiver stress. And some of its consequences include long-term physical injury, increased hospital visits and healthcare costs, and unfortunately premature deaths in some severe cases. So moving on to the second type, which is psychological, also called as emotional abuse. So definition of psychological abuse, it is the infliction of distress either through verbal or non-verbal acts, which can result in long-term cognitive and psychological harm. Some of the examples include verbal assaults like yelling, threats, humiliations, isolation from the loved ones, and manipulation. Some of the signs, psychological signs include depression, anxiety, withdrawal from normal activities, sudden changes in mood or personality, and fearfulness or agitation around certain individuals. And some of the behavioral signs to look for include low self-esteem, confusion, and loss of confidence. Risk factors are social isolation, mental health issues, and dependency on the caregiver. Consequences are depression, post-traumatic stress disorders, increased risk of cognitive decline, and high risk of suicide or self-neglect. Some assessment tools which we can use include geriatric depression scale, mini-mental status examination, and observation of caregiver interactions. Some of the clinical red flags are sudden onset or worsening of psychiatric symptoms without a clear medical cause and consistent fear of the caregiver. The third type is the financial abuse, which by definition refers to unauthorized or improper use of an elder's funds, property, or assets, often involving deception or coercion. Some of the examples include forging signatures on checks, unauthorized account withdrawals, coercing elders into financial decisions, misusing power of attorney, theft of property or valuables. Some of the financial signs include sudden changes in bank account balances and unexplained withdrawals, missing belongings or property, unpaid bills despite sufficient funds, and behavioral signs to look out for is fear or confusion about the financial matters and reluctance to speak about financial issues. Risk factors are cognitive decline, like dementia, lack of financial literacy, dependency on others for financial management. And some of the consequences include loss of savings or assets, inability to afford basic needs like medical care or housing, and loss of property or home. So these are the references which I used. Thank you.
Thanks so much for the great presentation. Do we have any question? Anybody, if there's any question, we can take some questions before proceeding to the next agenda.
Thank you very much. I just wanted to impact that how important this topic nowadays. I've been taking my USMLE step 2 recently, and a lot of questions came from this specific topic. So that's kind of really helpful.
I'm glad it's helping, especially the ethics.
Yeah. Actually, this topic is very common now. I mean, a lot of ethical questions came from this topic. Thank you. That was great.
Thank you.
Any other questions we have? Okay, I would like to thank Dr. Sakshi for the great presentation. Thank you so much. And I'll proceed to the next agenda. That's going to be sexual abuse and neglect. And do we have the presenter here?
Yes, I'm right
Dr.
here.
Mona?
Yes, I am. Hi, hello, everyone. Thank
Hello,
you very much for this opportunity. Thank you, Dr. Nadir. Thank you, Dr. Lima, for giving me the chance to present today. And as Dr. Lima mentioned, my topic would be abuse, but specifically only about sexual abuse and neglect. And I would go ahead and share my screen. Please let me know once you can see my screen. Is my screen visible? The PowerPoint?
Yes.
Yeah, we can see it.
Okay. So yeah, sexual abuse in geriatric population. Just a few words of definition and prevalence. Sexual abuse in elderly refers to any non-consensual sexual activity ranging from inappropriate touching to rape. It doesn't have to be fully complete like sexual act. It can also be just inappropriate touching. It also involves or it includes forced nudity, photographing in a sexual way, verbal sexual harassments, exploitations, or coercions. So it can also just be as simple as verbal. And some people may assume, oh, that's not sexual harassment, but it is sexual abuse. Sexual abuse of older adults is underreported. This could be for many reasons, but one that pops out right into my mind would be shame. It's not an easy topic to talk about, especially if it's sexual abuse. So someone may report physical abuse more easily than sexual abuse. Estimates suggest that 1 in 10 older adults experience some form of abuse, but sexual abuse may be less frequently reported or recognized, as I mentioned. Okay, just few points of risk factors. Physical frailty, vulnerability due to decreased mobility or illness. As older you get, the less mobility you would have and more illnesses, just generally speaking. So that could be a risk factor. Cognitive impairment and dementia. This is a big one. These group of people are especially very vulnerable when it comes to, reporting or expressing, let's say they don't like something or like just verbalizing any issues they may have. They would have great difficulties. Memory loss or confusion may make older adults unable to protect themselves or communicate abuse. Isolation, this is also a big one when it comes to the geriatric population, especially on this side of the world. Maybe from where we come, like from home, it could be a bit different, where there is a really strong like family or social support, if I may say. On this side of the world, I came to realize the older you get, the lonelier you are. Everyone is busy here. Everyone is just running around. Even if you're living with family members, everyone is just busy. So if you don't have a job, if you're just staying at home, you get lonely. And that could be like lonely and isolation. So social isolation increases vulnerability as perpetrators may target those with limited support system. Dependency, older adults depend on caregivers or institutions are at higher risk of abuse. So if you're depending, if you don't have the luxury of getting your own stuff done and you're depending on another person, by default, you are like in a weak position. Power imbalance, this is almost the same as the previous point. Caregivers or institution authority over the elder can create an environment where abuse is more likely to occur. Okay, so as I mentioned, there could be forms of sexual abuse, physical contact, unwanted touching, groping, or sexual assault, exploitation, coercing the elder into sexual acts for financial gain or other purposes, verbal abuse, usual use of sexually explicit language or threats to manipulate or degrade the elderly individual. And these are the kind of abuses that you don't really it's really difficult to catch, if I may say, because there's no evidence. Recognizing sexual abuse in the elderly, physical signs, genital or rectal trauma, bruising, bleeding, or injury to the genital or anal areas, especially in the absence of a clear explanation. So as physicians, we have a great responsibility when patients come to us and we have the I would say, privilege of having that kind of relation with patients. That gives us responsibility to make sure that even if they're not saying, like the physical signs, they may not be visible, but we should be sharp enough to kind of pick on cues and expose. So a patient may not come and say, complain of, let's say, genital trauma or, rectal pain or whatever. It could be not an easy topic to talk to a doctor, but our role should be to expose. So I think the message from this would be to expose, and of course with reasoning, not just, with reasoning, with good reasons to expose, but that should be on the first, at the top of your head as a physician. And then sexually transmitted infections, this could be a sign, presence of STI in elderly patients who are not sexually active. That's a red flag, or who are not able to provide a clear history of sexual activity. Unexplained injuries, bruising, scratches, or abrasions on the breast, thighs, or inner arms that may indicate forced sexual activity. Again, exposure. Difficulty walking or sitting, pain, bruising, or difficulty in sitting or walking could be linked to sexual trauma. If you are a doctor that is frequently seeing a certain patient, then you may see, they're not walking as they usually do, they're not able to sit, or like you can pick up on cues if you know them already. It could be difficult if you're seeing the patient for the first time, so you don't know if this is how they normally walk or, something is different. Incontinence or difficulty with toileting, sudden or unexplained incontinence, urinary or fecal, can be a sign of trauma or aberration. Behavioral and psychological signs, fear or anxiety, expressing fear, anxiety, or distress when a certain person is present, or avoiding being alone with a specific caregiver or family member. Reluctance to discuss personal issues, a sudden reluctance to discuss personal matters, particularly in the presence of certain individuals. Again, if you realize that they're kind of afraid, or they're not freely speaking in the presence of someone, that kind of gives you a clue. Withdrawal or depression, unexplained depression, social withdrawal, or a sudden decline in mental health could indicate emotional distress related to abuse. Unexplained change in sexual behavior, sudden or inappropriate sexual behavior, sexual talk, or expression that are out of character for the patient. Yeah, especially if you know the patient, it will kind of be easy to pick up on, oh, this is a different behavior. This person is not usually like this. Psychological trauma symptoms such as PTSD, nightmares, or flashbacks related to sexual abuse may emerge. Inconsistent or unclear explanations. I think this is a big one. If you're getting histories that are not, aligning with what you're seeing in the, physical examinations, that could be, okay, something may be going wrong and you may need to investigate more. Discrepancy in reports. Let's say a family member tells you something, but a caregiver tells you something else, and the stories are not matching. That could be a red flag. Direct or indirect disclosure. Of course, if you're lucky verbally, if they come and disclose an elder, if they are lucky, not us, if they are able to express and verbally tell you, disclose, that would be great, but that's very rare. Nonverbal indicators. Look for nonverbal cues, such as crying, signs of distress, or nervousness when discussing sensitive topics. Okay, a few words about prevention and intervention. Education, that's a big one. Teach elderly individuals about consents, boundaries, and the right to say no. The same way we teach children's, I believe we should do the same for elderly patients. They're almost the same, equivalently vulnerable as children are. Caregiver training, train caregivers to recognize signs of abuse and act ethically and respectfully. Report systems, ensure accessible and confidential channels for reporting abuse. So let's say if they're coming and you're not kind of sure, but you have the sense that, okay, maybe I need to give them out this pamphlet, in case they go back home and, they may want to use it. You're not sure, or you're not able to talk to them. Just give them resources that they can, use. Healthcare provider role, physicians and nurses should be trained to spot signs of abuse and to question patients when abuse is suspected. And that's part of what we're doing now. We have to be constantly involved in, like, to look out for signs, how to take history. You have to be very sensitive, and you cannot like come across as being judgmental, or these are things that we should be training on, I believe, on daily basis. Okay, the second portion would be neglect, abuse, and geriatric population. So elder neglect is the failure to meet an older adult basic needs, including food, water, shelter, hygiene, and medical care. Can be passive or aggressive. When it comes to neglect, abuse, it's someone, I believe someone, or that's what I read, that it can be done unintentionally. So with physical abuse or sexual abuse, the abuser clearly has bad intentions, but with neglect, someone could be neglected, although it's not something done intentionally, not deliberately. It's still abuse, it's not an excuse, like it's not justified, but it's something that can, you may not realize, or a caregiver may not realize that they're doing that. They're neglecting an older, family member or client. Elder neglect is one of the most common forms of elder abuse, which reports indicating it affects millions of elder people worldwide. Often occurs in family settings, but also in long-term care facilities and institutions. Risk factors, caregiver stress. The risk factors kind of overlap with the sexual, also with the other forms that Dr. Sakshi presented earlier. Family caregivers who are overwhelmed may neglect an elder's needs due to physical or emotional exhaustion. I think this is the most common risk factor. And as I said, it could be unintentional. So maybe they're not aware, and that's where training and constant training comes in hand. Cognitive decline. Elders with dementia or Alzheimer's may be more vulnerable to neglect due to their dependency and confusion. Isolation, lack of social support or visitations leading to unnoticed neglect. Financial hardship, limited resources may lead to neglect of basic needs such as nutrition or medical care. Physical neglect, failure to provide basic needs, as you said, food, water, shelter, clothing, or medical care. Emotional neglect, ignoring the elder's personal emotion needs, leading to loneliness, depression, or anxiety. As I said, this could be easily unnoticed. So you may be inflicting emotional neglect while you're really not even thinking that you're doing anything wrong. Medical neglect, failure to administer prescribed medication or delay or or avoiding necessary medical treatments. Personal care neglect, inability to help with activities of daily living such as bathing, dressing, or toileting. As a physician, a sign could be if your patient is not coming, like missing appointments. That could be the initial trigger for you to kind of, look into it deeper. Physical signs, malnutrition, dehydration, poor hygiene, untreated injuries or infection. Behavioral signs, withdrawal, depression, fearfulness, anxiety or lack of engagement with others. Environmental indicators, unkept living conditions, unsanitary surroundings, or lack of necessary medical supplies. Failure to follow up medical treatments, missing doctor's appointments, not taking medications prescribed, or untreated health problems. Okay, the prevention and intervention, family and community support, encourage strong social network and community engagement to reduce isolation. Regular monitoring, in-home visits by social workers, healthcare professionals, or family members to ensure well-being. Caregiver support, provide respite care for caregivers and offer resources to reduce caregiver burden. Training and awareness, educate caregivers about the importance of meeting an elder's basic needs. Here, as physicians, I was saying earlier, we do have the responsibility, and we are in a unique position where patients can open to us, And we are able, through our training, we're able to notice physical or emotional or behavioral signs that may indicate that abuse is going on. So it's a responsibility, and I just like to mention a few words, for ourselves, including starting with myself, like just a reminder to myself and to everyone else. Take a thorough history. Ask open-ended questions. When possible, speak with the elderly patient alone to ask open-ended questions in a neutral, non-judgmental manner. It's easy to say this, but when you actually want to apply it, I think it needs a lot of, training and a lot of effort to put into it. It's because it's just a very sensitive topic, and you want to make sure that you're helping the patient and not causing more harm. Obtain caregiver input, speak with caregivers, but be cautious of conflicts of interest. Compare their reports with the patient's account. Perform a comprehensive physical exam. As I said, I think exposure would be the big thing. Complete skin assessment. Check for signs of bruising, abrasions, pressure, sores, or other unusual marks. Genital and rectal exam. In case of suspected sexual abuse, ensure a sensitive, thorough examination of genital and rectal areas. Follow protocols for forensic evidence collection if needed. And I would like to say, as possible, with every step, try to take consent, explain what you're doing. They may not be realizing that you're trying to help. They may think you're the, abuser. So be very cautious and very gentle. Neurological and cognitive assessment. Evaluate cognitive function, particularly in case where neglect may be related to cognitive decline. Yes, documentation. I also believe this is a very big and important point, both to protect, the patient and to protect yourself. Document findings clearly. Detailed documentation. Document all findings thoroughly, including descriptions of injuries, physical signs of neglect, and any statement made by the elder person. Be objective and clear, as this may be important for legal proceedings. Also, if the patient is telling you a history, try to document like using exactly the patient's words. Even if it doesn't make sense to you, quote what the patient is saying exactly. And of course, you can add your own notes, but the words the patient used exactly, I think that's really important. Another thing is, as we mentioned earlier, if appropriate, if possible, if needed, with consent, take photos. That's part of documentation. And then ensure reporting, mandated reporting. In most jurisdictions, physicians are legally required to report suspected abuse and neglect. If sexual abuse or neglect is suspected, report it to adult protective services, social workers, or law enforcement. So some of what the points we discussed earlier, maybe you can do it physically, like for example, home visits, or seeing like the housing condition. As physicians, we may not do that, but you can connect them to social workers or to amazing people in the community where they can take care of that part. But that would be your responsibility to kind of connect them or, report. Referral to specialists, referral to social workers, geriatric specialists, or legal professionals may be necessary to ensure the patient's safety and well-being. Provide emotional support. This is a big one. Support and advocacy. Ensure the patient feels heard and supported. Discuss any safety concerns and advocate for the patient's protection, even if it means involving family, law enforcement, or protective services. These are my references, and thank you for listening.
Thank you so much, Dr. Mona, for the great presentation. It was very detailed and informative and very important. So thank you so much. We have one question in the chat, but I think that's going to be covered in the next topic that's going to be presented by Dr. Faaiza. Do we have any other questions for Dr. Mona about the presentation? Otherwise, we can go ahead and have the third topic by Dr. Faaiza. Dr. Faaiza, you can go ahead now.
Hello, good afternoon, everyone. So I'll just share my screen. Hope everyone can see the screen now.
No, it's still Dr. Aman's screen. Let me go ahead.
Is it stopped now? Did I?
Now it's Dr. Mana's screen still. So Dr. Mana, can you just minimize the PowerPoint presentation? If that's, yeah, we can see that now. Dr. Faaiza, you can go ahead. Thank you.
Thank you.
Hello, everyone. Just a brief introduction of myself. I am Dr. Faaiza. I'm an old medical graduate from India, Hyderabad, ECFMG certified, interested in internal medicine and psychiatry. I'll be presenting the topic on elder abuse screening and methods of prevention. So as my colleagues have previously discussed, what is elder abuse? It is intentional actions that cause harm or create a serious risk of harm, whether or not it's intended to a vulnerable elder by a caregiver or other person who stands in a trusted relationship, or a failure by a caregiver to satisfy the elder's basic needs or to protect the elder from harm. So elder abuse is common. It affects almost 5 to 10% of the older adults. And as for the screening of abuse, the American Medical Association recommends screening for all geriatric patients. Research suggests that only 1.4% of reported cases come from physicians. So we have the United States Preventive Security Task Force conclude that there is insufficient evidence to assess the balance of benefits versus the harms of screening all the elderly people. So as of now, there's no universal screening tool currently or any gold standard for screening. However, there have been many questionnaires which have come across as helpful. Elder Mistreatment Symposium identified 3 tools, which is called Elder Abuse Suspicion Index, HSEAST and VASS similarly, to help us screen the elder abuse. The U.S. Preventive Service Task Force included the Elder Abuse Suspicion Index, which is the EASI. It is a 2-minute, 6-item questionnaire with dichotomous variables, which includes yes or no. It was privately administered by the family physicians to cognitively intact older adults in a primary care setting. So little information is available on the prevalence of abuse among non-institutionalized elderly or vulnerable adults. As you said, it ranges from 2 to 5%. So some potential harms of screening, it may include shame, guilt, self-blame, fear of retaliation or abandonment by perpetrators, and the repercussions of the false positive results. So hence, screening practices for elder abuse are limited for many reasons. However, it's very important that all providers should be aware of the laws in their states for reporting suspected abuse. And not all states mandate reporting, and some provide clear guidance about what type of injuries should arouse suspicion. So this is the EASI Suspicion Index, and we have the first 5 questions to be asked to the patient, and which may be answered by yes or no within the past 12 months. And the 6th question, it's answerable to the physician, in which the elder abuse may be associated with findings such as poor eye contact, withdrawn nature, malnourishment, hygiene issues, cuts, bruises, inappropriate clothing, or medication compliance issues. And it should be answered by the doctor if he or she has noticed any of these today in the past 12 months. However, these screening tools are unable to, the USPSTF concluded there was insufficient evidence to assess the balance between benefits and harms of screening, and was unable to make a recommendation about screening for the general elderly population. And next we'll come to the prevention of abuse. One of the few points for prevention of abuse, we should always listen to caregivers and patients for the clues of abuse. and be very astute to recognizing abuse versus the normal aging process. Like, for example, the skin changes. In elderly, the patients, they have thin, fragile skin. It could be ecchymotic, but at some point, if you suspect abuse, it could be intentional. So we have to be very careful in identifying such skin changes, and confirm that patients who live alone have some support or connection. Encourage the use of adult daycare, respite services, and encourage a caregiver to use support groups, counseling, outlets that promote well-being, and whenever prudent, encourage multiple people to be involved in finances, and refer caregivers who have substance issues to get help. And the previous questionnaire, the EASI, which we have discussed, it has a sensitivity of 47% and a specificity of 75%, meaning that it has a high rate of true positives as compared to the sensitivity. And this pie chart shows us the graphical representation of the perpetrators of abuse. So as you can see, 56% in this case is the service provider or the caregiver. And in 21%, it'll be the adult child, in most cases, son, 4% friend or neighbor, 10% other relative, 1% self, and 8% spouse. Coming to the intervention, the successful interventions in cases of elder abuse are typically interprofessional, ongoing, community-based, and resource-intensive. So the most important task as a physician, it becomes to recognize and identify elder abuse and to become familiar with resources for the intervention that are available in the local community, and to refer to the patient to and coordinate care with those resources. For example, in a hospital inpatient setting, it would be the social work who would the physician contact and just gather the resources for a safe community if prior to discharging an elderly patient, if you suspect abuse. As of now, there have been no large high-quality controlled studies of specific and discrete interventions. This has identified as a critical knowledge gap in the field. In the US, all but 5 states have some sort of mandatory reporting of elder abuse to Adult Protective Services. And according to the American Bar Association, however, laws governing reporting are very diverse in content and structure and extremely challenging to categorize and explain. So this shows that it is a very nuanced approach, and it should be multi-dimension, involving a lot of members prior to reporting abuse. Adult protection laws in Canada similarly vary by province and territories. This is the graph. This is like a flow chart which a physician can follow. Once you suspect abuse, first you determine the patient's capacity. It could be cognitive capacity and the mental capacity. And once you have declared the patient as competent or capable, you have to assess for imminent safety, clearly state your concerns, seek explicit permission to discuss concerns with family members or other supportive individuals. So we have to do this all by consent. Once the patient is capable, educate patient with permission the caregiver about abuse and tendency for it to increase with time. Providing local resources, including daycare programs, home care, respite care, legal services, shelters, and consider creating an emergency safety plan, and consider reporting to legal authorities. However, in cases where you find the patient as incapable or cognitively not intact, you assess and address any reversible medical cause of incapacity. And after that, if that is not addressable, and then if the patient is completely permanently incapable, you identify the power of attorney. And if the power of attorney of the patient is acting in its best interest, you follow the same guidelines of here when you do when the patient is capable. If you have concern that the patient is not acting in the best interest or is the abuser in question, you consider involving other family members or contacting Office of the Public Guardian and trustee and legal authorities, and make sure you have frequent follow-up and consider arrangement of a house call by a physician or a home care agency. So an important caveat on this flow chart would be to ensure that the incapable patient does not have any reversible medical causes of incapacity that should be addressed before seeking guardianship. And all abused older adults should be offered more frequent medical follow-up And in any case, if they don't show up to the clinic, because of transportation issues or anything, most of the hospital, and I think most of the states in the United States of America, they offer mobile crisis teams, which can reach out to the patient's address and do wellness visits if asked by the provider. And this table shows us the groups which are involved and the groups which the physician, along with his team, can report to in case of suspected elder abuse. So first and foremost, we have the APS, which is the Adult Protective Services, similar to Child Protective Services, which we have here, and they serve as guardians in some states. Followed by home health care agencies and personnel, which are important in both detection and mitigation of abuse. And then next, we have community, non-governmental or non-profit services and programs for older adults. They have programs exclusively devoted to preventing elder abuse or dealing with its manifestation. Example, daily money management and caregiver support. And of course, we have the police, which are often the first responders in case of elder abuse. We have the district attorney's office, who prosecutes cases of elder abuse, the housing authority, which handles issues involving eviction, squatting, or misuse of housing. Eviction and homelessness can be a manifestation of, sorry, just skip that slide. Yes, so eviction and homelessness can be a manifestation of financial exploitation, and the legal service agencies which handle the myriad legal issues that are raised in cases of elder abuse include decision-making capacity, living wills, and guardianship. And in most cases, guardians may be financial abusers. And the other 2-3 groups which are involved, which are not able to present in the slide, which include nursing homes, hospital personnel, which need to be prepared to identify cases of elder abuse. The nursing homes, they can use excess capacity to house victims safely and provide services. And part of the growing movement in the United States is to provide shelter to the abused older persons. And the last is the banks and the financial service industry, which can detect exploitation of older persons' finances. Then we have the Adult Protective Services. It's a federal program that receives mandatory reports of suspected abuse and is typically at the center of case investigation. So we have 49 states, except for New York, have mandatory reporting laws that require designated reporters, including physicians, to report even the suspicion of abuse to APS, law enforcement, or a regulatory agency. So typically, what would an APS worker do? It would visit the home, conduct an investigation with the goal of verifying or refuting the concern. And if the abuse is identified, interventions are then undertaken that are both tailored to the circumstances of the victim's situation and highly dependent on the resources of the environment and the dynamics of the family. So in these cases, physicians can serve as a highly useful resource for APS workers as they pursue their investigation. And because of the prevalence of cognitive impairment from dementia, which is the most common cause of incapacity in geriatric population, a critical consideration in all cases of elder abuse is whether the victim has decision-making capacity and is able to accept or refuse intervention. And evidence suggests that interprofessional teams, as I mentioned before, are multidisciplinary, consisting of physicians, social workers, law enforcement, attorneys, and other community participants working together, are the best practical approach to assisting victims. Indeed, one of the most helpful contributions a physician can make with regard to elder abuse is to serve as the catalyst for the formation of the team. And physicians can cultivate these relationships both to serve victims of elder abuse and as a step towards developing interprofessional teams in their communities. So the teams could meet on a regular basis to discuss difficult cases in the local community and to coordinate an effective response. A plan of action is developed with individual team members assigned to specific tasks, and a time frame for a follow-up is specified. So these are some of the resources which the victims can contact or the physicians. We have the national resources, which includes the elder abuse helplines and hotlines. We have the websites, which are National Center on Elder Abuse and National Institute on Aging, which has all the guidelines and the recommendations to follow in case of suspected elder abuse, and the CDC and the National Institute of Justice as well. So we come to the question part, which is the last part of the presentation. Yeah, while making a home visit to a bedridden 89-year-old man, you note that he's sketchetic, dehydrated, but cognitively intact. He states he is not receiving his medicine, that his granddaughter, his caregiver, is more interested in my check. He is unhappy, but asks you not to tell because he does not want to go to a nursing home. What would you do? Talk with the granddaughter and evaluate her ability to care for the patient? Visit the patient more frequently to ensure that his condition does not deteriorate? C, report the situation to the state agency? Or D, honor the patient's wishes because a competent patient has the right to determine care? The answers can be in the chat box. We have 1D. Okay, so the answer will be C, which is report the situation to the appropriate state agency. And that's what one would do. You contact the local authorities, even though you have, patient is saying responsible for his care. You do notify the state authorities. The next question is, which of the following statements is true concerning elder maltreatment? This problem is found mainly in families of lower socioeconomic status. B, an elderly adult being mistreated usually seek help. Or C, routine screening is indicated as part of the care of the older adults. Or D, in most instances of elder mistreatment, a predictable cycle of physical violence directed at the older adult followed by a period of remorse on the part of the perpetrator is the norm. Any more answers? Yeah, the correct answer is C, which is routine screening is indicated as part of the care of an older adult. Although generalized guidelines say it's not, highly effective and research has not shown, but we do use it, the routine screening, as a general care, part of the care. And the most commonly reported form of elder maltreatment is physical abuse, or B, sexual exploitation, C, financial exploitation, or D, neglect. Yep, that's correct. The answer is D, neglect. And that's it. That's the end of my presentation. I'm happy to take any questions, or Dr. Lama can follow for me.
Thanks so much, Dr. Faaiza, for the great and detailed presentation. It was well informative and very important to implement in clinical practice for patient care. So thanks so much. And we can take some questions if we have questions from the team. Any questions for the presenter? Okay, so I just want to just point out 2 or 3 points on the first agenda. It's sometimes, elder abuse it's more common, I think, in a nursing home and post-acute care setting, because there are a lot of elderly patients in there. But to mention just a few points on physical abuse, as financial and sexual abuse, I had 3 experiences on all the 3. So the first one is that was a neglect by healthcare professionals in the facility. A patient had a fall, which was not reported to the provider, and patient was found to have like bimalleolar ankle fracture after 3-4 days. It was just infected as well, so she was sent out to the hospital, which was reported to the state and to everybody involved in the care. So that was the first case neglect by the healthcare personnel by themselves as well. The second one is a financial abuse. That was a patient admitted for post-acute care after a myocardial infarction, and the POA was trying to just force the patient to be in comfort and hospice care, but the patient was denying that. So after the nursing staff identified the problem, it was notified to me and everybody involved in the care. So that was reported to the state as well, to the police, and the POA was removed from the care, and other family members take over. And the other was a sexual assault claim by a post-acute care patient. But that was not a real, incident. She was reporting sexual abuse and rape in the facility, but she had a major surgery and she was having a delirium and behavioral change after the surgery. So it was found that that was just, part of the delirium, but it was reported properly to the state and to the police as well. So my take on these 3 cases is just documentation and reporting properly to everybody involved in the care is very critical, for the patient and for the provider as well. So I would just want to point out these points. So if there are not any more questions, we will go to the second agenda, AI in medical research. And that's going to be presented by Dr. Mona Eshag. So Dr. Mona, are you here?
Hello, everyone. Yes, I am here. I am
Okay.
Dr. Yes.
Go ahead, please. Thank you.
Okay, thank you. I am Dr. Mona Muhyiddin, and I will present AI use in health care and medical research. I will share my screen. Okay, just a minute to share my screen.
Not yet. It's not shared yet.
Okay.
Okay, it's coming, I think.
Okay. Is it open now?
Yes, go ahead, please.
Okay. First, artificial intelligence. It is development of computer system or technologies that can perform tasks that normally require human intelligence. In another word, it is the application of algorithm in existing data to perform a task on behalf or in assistance of human being. So we have pre-existing data and we apply algorithm to it to perform a task for that normally require human intelligence. Okay. AI in health care and medicine. Artificial intelligence is a powerful tool that is transforming healthcare and medicine by enhancing patient outcome, advancing biomedical education, and accelerating research. There is examples of artificial intelligence application in healthcare, like management of patient data and clinical follow-up, as there may be a lot of data stored for patient, and it will be exhausting for the physicians to follow up all this data. So the use of AI can help us to monitor these data and follow up the patient symptoms. Another use is support the diagnosis of different illnesses. There are some examples for this. Mostly diagnosis errors occur due to physician error, like physician fatigue and exhaustion, or technology limitation or resources limitation. This can be overcome by use of artificial intelligence. But diagnosis cannot be mainly based on AI. It has to be assisted by human being presence. Also, AI can be used in recommendation of treatment for patients. There is a company that use AI model to predict patient response to certain medication based on clinical data or genetic factors of the patient. We can also use AI in disease predictions for hypertension and diabetes based on patient characteristics like exercise, sleeping patterns, and current glucose levels. For example, can predict diabetes mellitus occurrence and glucose levels in the futures. Also, AI can be used in designing new drugs and analyzing human data point. It can be also used in medical education, as there are some education facilities that use AI patients for students to learn on them. For example, history taking. AI can also generate new options based on the given data and enhance human creativity. AI is a mirror. AI is a mirror that can give us a reflection on our data and detect any bias. Sometimes we cannot see the full perspective of our data, but when we apply it to AI, it can give us some point that we didn't see in the first place, like biases that were not detected by human that are present in our data. Okay, there is a question that raises itself, can AI replace physicians in the future? And I found an answer to this question in the Stanford lecture, saying that AI cannot replace physicians. However, physicians that use AI can replace physicians that don't, because it is advancing a system that can assist in many aspects of patient care. AI in medical research. AI can be used in many aspects of medical research with the potential to increase efficiency and speed in research processes and enhancement of the accuracy of diagnostic and predictions, in addition to reduction of research cost. AI in medical research, main areas of AI impact include data analysis and management. AI can be used for processing large data sets like electronic health records. It can also provide predictive analytics for patients' outcome. Another aspect is medical imaging. AI algorithm can be used in interpreting radiological images like MRIs and CT scans and enhancing diagnostic accuracy. We can also use AI in clinical trials. AI models can use patient data from medical records to identify eligible patients, monitoring of patient safety and risk management, data analysis and management, which can result in significant reduction of the trial time and cost. We can also use AI in public health and epidemiology, as AI models can predict the spread of a disease and analyze the effectiveness of public health interventions and also assist in vaccine development. We can also use AI in scientific writing for medical research. AI tools can reduce the time needed to prepare and revise manuscripts. They can also help with grammatical errors, brainstorm ideas, and collect and synthesize data. Example is a famous tool that is currently used, ChatGPT. It is currently a famous tool that was previously credited as co-author in different papers. However, it has some limitations like referencing incorrect data and creating fake citation. That issue was raised shortly after researchers start using ChatGPT for scientific writing, and some researchers mainly rely on ChatGPT for scientific writing without checking after the data it provided. It is very helpful for scientific writing and rephrasing. However, it should assist the human researcher and not replace the need for human in scientific writing. It cannot the scientific paper cannot be fully generated by ChatGPT. It will contain a lot of mistakes. It have to be written by human in assistance with ChatGPT. Another tool is consensus, which can guide the initial literature review and provide useful papers to answer some research questions. Also, AI can be used in natural language processing. Natural language processing is used to analyze clinical notes, research papers, and medical records to extract relevant information. AI have several limitations in medical research use. First is data quality and availability. AI models require large, high-quality data set to function effectively. So if we don't have initial data for AI, we cannot apply it in medical research. We have to have large, high-quality data set in order to apply an algorithm to use an artificial intelligence model. There is bias in AI models. AI system can inherit biases from the data they are trained on, leading to disparities in medical outcomes. So if we enter biased data to AI, it will create a biased model based on the data we entered to the programs. Ethical and legal concerns, mainly around data privacy and patient consent. And finally, security risk. AI systems, especially those that rely on sensitive medical data, are vulnerable to cybersecurity risk. If someone hacked to the program that was used for medical research, he can get an access to patient data that contain a lot of information about certain patient that should not be shared with anyone. So the models used in artificial intelligence have to be secured to overcome this risk. Any question? I hope a simple question that I can answer.
Thank you so much, Dr. Mona, for the great presentation. It was well informative and very important. Thank you. Any questions? Otherwise, we can go ahead continue with our next presentation. It's going to be any questions? Sorry. Okay, thank you so much, Dr. Mona. We can go ahead and proceed to our next topic. It's YouTube and medical research and other very important parts. It's going to be presented by Dr. Ali. Dr. Ali, are you here?
Yes, I am.
Okay, you can go ahead if you're ready. Thank you.
Let me share my screen. Okay, hello everyone, I'm Dr. Ali Abubakar. Today we are learning how to create a new YouTube channel, uploading video on it, and take a look of some of the best medical channel in YouTube. Okay, YouTube is an American video sharing platform, headquartered in California, I think. It's one of the Google platform, was created in 2005. Now to create a YouTube channel, you need to have a YouTube account. YouTube account, same as Google account, simply you need to create a Google account. So to create a Google account, we go to account.google.com and click on sign up. Go through the whole process and sign up for brand new YouTube account or Google account. So here, uh, you fill the required information. It's very simple. And your confirmation page will appear like this page. Okay, when we finish creating a Google account, just go to youtube.com and sign in with that Google account. You just create it. Your Google account is actually your YouTube account as well, as I said. Okay, let's go to YouTube. Okay, I already have an account and I sign in. It appears like this. So the next step is to click the icon on the corner here. And we click on create channel. Okay, now the default name that is selected here is obviously the Google account name, but you can change that in case you want a different name for your channel. We press on create a channel. Now the channel is created. You can add some work on it to change the profile picture and okay, when you press on customize the channel, you can change the picture, you can add description to your channel, and you can add also some links, your email. Okay, now the channel is already done. It's created. Uh, Now, if you want to upload a video, we press here. Okay, we press here. Then we press on upload video. Okay, we can use from here. If we choose, for example, this video. Now the video is uploading. You can add a title to the video, and you can write a description about your video. And you also here, you ask about if this video is for kids or not. It's very simple. Then when you fill those documents, then you press on next and your video will be uploaded. Okay, we go back to the PowerPoint. Okay, finally, I put some examples of useful channels like Midcram, both certified pulmonologists making amazing video kind of guiding you through like drawing illustrations of pretty much any topics in medicine. Is very interesting and high quality teaching. Channel number 2 is Osmosis. Is obviously a company that many people on the medical journey, medical school particularly, know very well. It's a high quality content in animated style. You are probably familiar also with the Khan Academy. Khan teaching style usually done in black or white board and is very useful for board exams. For board exams, is very useful. Lecture. I see the teaching style is a little bit different. It's more kind of PowerPoint with one instructor, kind of talking about various topics from basic sciences to clinical medicine. This is Dr. Nadil channel. Don't forget to subscribe to this channel. It contains all previous sessions of telegeriatric fellow. And there are different channels for board exam like Dictor and Jeep, for OET like E2 language and more. Okay, this is the end of my presentation. Thank you.
Thanks so much, Dr. Ali, for the important presentation. Thank you. Any questions on YouTube?
Yes, please. I have, if you can just go back to the first slide of the channels you recommended, Dr. Ali.
Dr. Ali? This one?
Yes, thank you. Yeah. Thank you so much.
Okay. Any questions on it, or you just want to just note that?
No, I just wanted to write it down.
Okay. Okay. Thank you so much. Okay. Any other question? Okay, thank you so much, Dr. Ali, once again. And I just want to point out just a few points on YouTube. And, it's just a very important platform for study, for a lot of stuffs, and, for application preparation. There are very important channels on it, but we can also be part of it. And if anyone is interested to have their own YouTube channel, and this is how to create a YouTube channel, and you can even make some money on it as a side hustle as well, or you can just work on it to just help other IMGs if you're interested in volunteering on that part to just successfully match in residency once you got your spot, or if you're interested to just have some information for the general public of your own community, you can do that as well. You can use it for a wide variety of ideas as well. So, but to make some money on it, there is what we call it a YouTube monetization policy or something. If you're interested to make some money on it as well, but the policy is if you have a new channel on YouTube, you have to have 1,000 subscribers and about 4,000 valid public watch hours in 12 months. So if you meet those two criteria, you can monetize your channel and make some money based on your YouTube content. So yeah, I just want to add that one as well. Thank you so much, Dr. Ali, for the great presentation. And we can go ahead and have our last presentation. It's going to be presented by Dr. Emad. It's about critical appraisal. Dr. Emad, are you here?
Yes, I am.
Okay, if you're ready, you can go ahead. Thank you.
Okay. Just sharing my screen. So, hello everyone. My name is Mohammad Emad. I'm a student. Today our topic of presentation would be critical appraisal. It's a bit of a tough topic to go through entirely. It's like programming or learning a language. It's better learned by doing. But today, hopefully, we'll cover all the major points, all the broad topics, so you understand going into it. The best way to learn this is to actually try and apply yourself and try and actually do a critical appraisal of a research paper. Am I clear? Is my sound clear? I'm not sure.
Yes, please go ahead.
Okay. So the easiest way we can sum up this is by this question. Would you put a tomato in a fruit salad? Because we all know that tomato is a fruit because it comes from the flowering part of the plant. But can it be used in a fruit salad? Well, I mean, you can if you want, but it won't taste good. So this is a very important distinction. Knowledge is knowing that tomato is a fruit, while wisdom is knowing that it usually does not belong in a fruit salad. So what are we expecting from this presentation? We want to learn what is critical appraisal. We want to learn why is it important. We want to recognize the key concepts involved in critical appraisal, and we're going to have an overview of the CASP, which is a checklist used in assessment of critical appraisal. There are several different checklists depending on the type of research paper. We're going to see how it is applied to a cross-sectional study, but you can use it or a modified version of it to apply in any other type of study. And in the end of this presentation, I'm going to supply you with some additional resources so you can learn to do this better. So like the tomato example, not all research is created equal. There's difference in quality, there's different bias. And even good research might not be relevant to your situation. So this is the whole point of a critical appraisal, is to find the research that is both valid, is trustworthy, and most importantly, relevant to what you want to apply it on. So why do we need critical appraisal? Simply put, is to help us judge if we can use a research paper to inform our clinical decision, our healthcare policies, and or further research. So the key term here is use. So whenever we have a paper or a piece of medical research, we want to use it, we want to apply it. And this application requires us to know, to perform a critical appraisal. Whether we want to apply it in taking a certain clinical decision, whether we want to apply it as part of a team to develop a healthcare policy, or if we're writing a research paper of our own, and we want to include it in our research. So what is a critical appraisal? If you want to put it simply, it's just a way of systematically
You're muted, Dr. Emad.
Can you hear me?
Oh, yeah, you're back. Thank you.
Okay. So simply put, it's a way to evaluate research. The longer definition is a process of carefully and systematically assessing a research paper to judge three criteria: its validity, its trustworthiness, and its value and relevance. Each of these criteria we're going to expound on more, but basically this is what we want. We want to judge if the research is valid, i.e. it is internally consistent, it has internal validity. Is it trustworthy, i.e. is it precise, and what does it report compared to other pieces of research? And lastly, and most importantly, its value and relevance. The things reported in this research, can we apply them to our clinical question, or are they relevant to our situation? So before we do critical appraisal, we need some basic skills. First off, we need to be fairly familiar with the different types of study designs, their points of strengths and weaknesses, like cross-sectional studies, cohort studies. We want to know what they're good at and what they're bad at. So we'll be able to identify the deficiencies in their design. We need to be able to identify biases in the research. We need to reporting bias and other types of biases. And we need to be able to judge the practical relevance of research findings. And all this stuff comes with practice and comes with when we do this several times. And of course, we can read about it, and improving our theoretical knowledge on these topics will help us greatly, but practice is still the best way of learning these skills. In this presentation, we're going to go through some of things that might pertain to these skills, but the skills really need time to develop. So our first point, validity. Validity is also known as internal validity, and this is a point of confusion because the other criteria, trustworthiness, is also comprised of precision and external validity. So the word validity is used in several parts, and this can be slightly disorienting. So internal validity is validity, and external validity is part of trustworthiness. So what do we mean by internal validity? There's an element here. When we mean internal validity, we want to know if the research is internally consistent. That means we want to know to assess the soundness or rigor of the particular study, and to the extent to which the conclusion of the study is true within the specific context of the research. I.e., given what we know, we forget everything outside of the paper we're looking at. We look at the paper, we see, given the study design, the study limitation, the methods used, given this criteria, is the conclusion that the authors have drawn valid or not? So this is internal validity, or as we know it as validity. Here we look at the design of the study. Is it suitable for what the aim of the study the researcher want to study? We will look at the method, i.e. the methodology used in the design study, and lastly, look at the procedure, i.e. how the authors have implemented the design of the study. In a more practical sense, we look at the aims and objectives of the study. We want to see if the authors clearly identified their population of interest, have clearly identified the interventional outcome, that they use an appropriate study design, like a case control study or RCT, suitable for addressing the research question. Have they used an appropriate methodology? So is the design that was stated carried out appropriately? And was it explained sufficiently? So if another person wanted to repeat the experiment or the research, he can verify the results on their own. So not only does it have to be explained, it has to be explained sufficiently. And this is actually a hard criteria. Not even good research paper does not always cover this sufficiently. But usually, if you email the authors or if you check with the authors, they can provide you with more details on the study implementation. But when you're assessing a study, you only care about what's written in the paper itself. So you don't care about when you call the authors. So this is the first point of validity. The second point is the trustworthiness of the results. So trustworthiness can be divided into 2 points: precision and external validity. Precision from the word is simply how precise the study is. So it evaluates the reported results within the study. Where the findings stated clearly and where the findings justified, are the results precise? Depending on the type of research and method used, was the data analyzed rigorously? And was it done properly according to a pre-specified protocol? So this would be explained in the methodology section, on the statistical analysis section. And usually to assess this, sometimes you need some background in statistical analysis. The author should hopefully explain it well, explain why they chose each specific test and how they implemented it. And the second point in trustworthiness is external validity. External validity simply compares the result of this research with the existing body of evidence. So you see the authors presenting certain results, and you compare these results with what exists in the literature. Hopefully, the authors themselves should have provided this comparison in their discussion section. And if there's some major contradictions, the authors should address why they think these contradictions exist. So you don't only assess for the presence of contradiction, you also assess for the justifications given by the authors for this contradiction. Lastly, you want to assess the value and relevance. So what are the practical relevance of this finding? Who can the finding be applied to beyond the confines of the article being appraised? And this is, of course, a very important issue. As you can, if any of you is interested in cardiology, for example, you know that a lot of the initial research and up until now, most of the research have been done on males and in white Caucasian males. And these results have been generalized to females. And recently, in the last couple of decades, people have been realizing that the presentation of a lot of cardiac issues is not the same in females like it is in males, and it's not the same in the elderly population as in relatively healthy young males. And this has actual burden. People die because they are misdiagnosed or they're underdiagnosed. So applying specific research to a specific population, even when it's just detection, has very, very real and palpable effects on the real world. When you're assessing and the relevance, what you want to know is the relevance, the outcome, and the local applications. Basically, the relevance is what is the practical relevance of this finding? Can they be applied beyond the research? So can the particular finding be generalized to other populations other than the population where they were originally studied? Are there any benefit, worth, harm, cost associated? So for example, if there's some study that suggests there is a chemotherapy, for example, that can extend the average life of a participant by 10 months, for example, and the drug is very, very expensive. Yeah, this is a discussion to be had. Is it worth the harm and the cost? The benefit, is it worth the cost and the burden it would put on the patient? This is a discussion to be had with the patient. Were all the important outcomes considered? So in this study that, for example, studies an effect of a chemotherapeutic drug, where was the only measured outcome just survival, or did also measure morbidity? Did the drug prolong morbidity? Did the prolong suffering? So you have to consider other stuff that can result from the study. And a good, well-designed study should account for all these variables. So not just the outcomes important to the researcher, but also to the patient. So yeah, oftentimes when you're developing a drug or trying to publish a paper, the researcher, what the researcher cares about and what the patient cares about are not necessarily the same thing. So the researcher would want a positive result so he can publish. Patients may not see the relevance of a small positive results if it was an expense of suffering or increased cost, or if the result was even marginal. Why would you pay a lot of money for a small marginal result? So the outcomes are important not just to the researcher but also to the patient. The second thing, can the results be applied locally? So are the study areas, study participants, the treatments investigated, and the practice standard comparable to the local situations? So yeah, you have to see if a certain drug improved the survival in a certain population in a developed country. This does not necessarily mean that can apply in a country with lower resources. Maybe have different variables. It doesn't mean that we should not investigate it. Of course, we should investigate it, but you have to keep this in mind when you want to apply or you want to generalize the results of a certain study. So how do we actually do this? So we're speaking in very generalized terms, right? So we're speaking about in general principles, we're speaking about ideas, but in practice, how do we actually perform a critical appraisal? So as we said, a critical appraisal is a systemic process. And whenever you hear this phrase, a systemic process, usually there's a checklist involved. Because let's face it, humans are not very systemic creatures. We forget half of the steps if they're not completely routine. So whenever we have something where you have to be careful and you have to be systematic, usually involves a checklist. And there are several checklists that have been put to aid us in undergoing a successful critical appraisal. The Cochrane Institute in particular have very good checklist. Here I will present something called the CASP checklist, which is a critical appraisal skills program. It's one of the best ones. It's originally developed to undergo critical appraisal, systematic reviews and case studies, but it can be adapted, as in this case, to cover cross-sectional studies. Cross-sectional studies are generally the simplest type of studies. There are some of the less limited ones in terms of power, but they are the simplest. So I'm going to use them as an example. Hopefully, you can understand this term, so you can generalize it if you want to apply this in other types of studies. So, however, as stated in the beginning, other skills are also vital. You have to know, as I said, you have to have good knowledge of the study design. You have to have the ability to identify different types of biases. You have to have the ability to judge the practical relevance of research findings. So the use of the CASP checklist in assessing cross-sectional studies. The CASP checklist for cross-sectional studies consists of 20 questions divided into sections. Each section covered the relevant section of the paper. So conveniently, this checklist has been developed not by key concepts of validity, trustworthiness, and relevance, but the sections are into introduction, methodology, result, discussion, and the last term is not conclusion, actually, it's others. So conclusion is wrong, it's supposed to be others. It's supposed to be introduction, methods, result, discussion, and so it's conveniently the same layout, the same general layout as a research paper, which makes it easier to implement. The key concepts of validity, trustworthiness, relevance are not addressed separately, but are interwoven when appropriate. So this is the checklist, this page and this page. Let's look at it again. So introduction, the first question, what are the aims and the objectives of the study? Were they clear? Yes and no. And then you have comments. And the same, we're going to go through each and every one of these questions now. Okay, so the first question in the introduction. Were the aims of the study, objectives of the study, were they clearly stated? So the aims of the study will tell us if the study addresses an appropriate and clearly focused question. So obviously, when we want to measure something, it has to be a clearly well-phrased question. It has to be something that can be measured, and it has to be something that can be measured given the limitations of the study design. Ideal and aim should be stated both at the beginning of the abstract and the end of the introduction. If the answer to question 1 is no, so if you read the abstract, and practically if you have a paper in front of you and you read the abstract and you put your hand on the abstract and you think to yourself, what is the aim of this study, and you cannot answer this, there's obviously a problem. So this is the first thing you should know about the study. What is the aim of the study? Then it will make it difficult to assess some of the other questions in the critical appraisal process, making it one of the most important criteria. Methods, the methodology is obviously one of the most important ones. Almost half of the questions, of the 20 questions, are questions in the methodology. So the first one is, was the study design appropriate for the stated aim? I.e., did the authors use an appropriate study design considering what they want to study or measure? Was the sample size justified? So again, if you want to measure something that is very rare, you have a small sample size, you're very unlikely to detect it. Was the target reference population clearly defined? So you have exactly who is participating in this study, and is this population representative of what you're presenting in the conclusion? Was the sample frame taken from an appropriate population base so that it closely represented the target population? This is what I just said. So the way you sampled your sample, has it been taken from an appropriate base? So you can generalize it. If, for example, you taken a sample of from elderly patients, elderly female patients in a geriatric center, and then you want to publish something about females in general, this is of course a bad study design. You cannot generalize the results in elderly females to all females. Was the selection process likely to select subjects that were representative of the target reference population under investigation? This is a very good question because it points us toward the direction of selection bias. And this is a huge problem when we have polls, for example, or which are very easy to perform, but they're very biased because people who answer polls, who voluntarily answer polls, are not generally representative of samples. People who volunteer their time willingly to a prompt are not generally representative of the general population. And this is seen clearly in political polls where you have, if you plot, for example, the political stance of all people in a population, you generally have something like a bell curve. But if you plot the same thing in most political polls, you have a biconvergence. You have two hills instead of one, two medians, because polls selectively select for extremes of data. So when there's self-selection, you can find this problem. And this can also be seen in patients who are very sick, for example, or patients who are hypochondriacs, or patients who are eager, they have a sick child, for example. All those patients would be self-selecting patients, and they will not represent the population as a whole. Were the measures undertaken to address categories non-responders? So yeah, why do you have non-responders? And if you have non-responders, are they simply randomly non-responders or categorically non-responders? So if there's an issue that forces an entire group to not respond to your research, then this, by definition, would make your research biased. Not necessarily useless, but biased. Because what is the characteristic that made the entire group of people not responding to your certain questionnaire? So for example, if you have a study on blood donations, for example, and you live in an area where you have a lot of Jehovah's Witnesses and they refuse to answer your question, your results would be simply biased because they're a huge group of, they're a large group of people. They are represented in the community, like, and they will not be represented in your results. If you're here, I'm clarifying that I'm talking about the research where you're asking the opinions on people on blood donation, not simply blood donation. Were the risk factors and outcome variables measured appropriate to the aims of the study? So did you measure what you're reporting? This is a very, very good sign to see if the research is well designed. If the research paper is reporting something while measuring something else, and this you'd find if you're following the fitness scene, especially the scientific side of the scene, you find this all the time. Every single small tick in clinical significance, you find a lot of articles written about it that report stuff that are not being measured. So this is a very important. Is what you're reporting in the results the same thing that you measured? This is a very important distinction. Were the risk factors and outcome variable measured correctly using the instrument measure that have been tailored, piloted, or published previously? So did you measure correctly using proven methods? Is it clear what was used to determine the statistical significance of precision estimates? So the author have to tell us what they used to determine statistical significance. They cannot just say the data is statistically significant. They have to be very specific and tell us they used the p-value and they set the significance of less than 0.05, for example, and they have to tell us the confidence interval. If they did not report that, then this is a point off. Where the methods, including statistical methods, sufficiently described to enable them to be repeated. Again, this is a point where a lot of studies you'd find this deficient. Even good studies, really good studies, always have to report this, but even published studies sometimes do not publish good enough methodologies, so you have to repeat their studies. You have to usually contact the authors to get further information. So now we're going to address the methodology questions one by one. So the first question, what was the study design appropriate for the stated aims? So how appropriate is the use of cross-sectional study? Remember, we're doing this an example in cross-sectional study, but you can replace cross-sectional study with any other type, given you know the different strong points and weaknesses of different study designs. So cross-sectional studies are observational studies. They provide a description of the population at a given time. They're useful in assessing the prevalence and for testing for association and differences between groups. They're not good at assessing the incidence of a specific disease. So if you find a research that has incidence and it has a cross-sectional study design, then by default, this is a very bad research. It's very rarely that you can use a cross-sectional study to measure incidence. So it's useful in assessing prevalence and associations between two groups because you take a cross-sectional snapshot of the population. Example of cross-sectional study, but it's terrible. This is a very important word. This is association, not causation. So since unlike cohort study, for example, where you measure, where you follow a patient and you can see something develop than the other, here you only know that the two factors are associated with each other. You don't know whether the two factors are causative. You don't know whether they have a third factor that causes them both. You don't know the actual association. You don't even know if it's just an incidental association. You just know there's association. For example, a cross-sectional study design includes a point-in-time survey, analysis of records, audits of practice. This is an example of cross-sectional studies. You should try and decide if cross-sectional study design is appropriate for the question being asked by the researcher. So was the sample size justified? This is very important as crucial as a sample size profoundly affect the significance of the outcome. This is, if you can remember the statistical analysis part of step 1, type 1 errors and type 2 errors are frequently asked, frequently tested. A type 1 error is drawing significant conclusions when there's no real differences. And it's a function of the p-value, it's a function of p-value sometimes referred to as a false positive. So when you have a type 1 error, we say something is false positive. So there is no association in reality and we find an association. Type 2 error is a false negative when there is an association, like we will fail to detect this association, usually because we don't have sufficient sample size. So type 2 error, if you can see this if you read a new paper that's been published, a cross-sectional study, and it reports no association between two things that we really know that are very well associated, like LDL level or LDL-C level and heart disease, for example, and you find no association, and then you look at the sample size and you see it's like 30 patients. This is clearly a very big mistake because the sample size was too small to detect an association, so we cannot take the conclusions of this study seriously. They're not justified. This would be trustworthiness. So it won't be internal validity because the methodology checks out. So it won't be a problem with internal validity. It is externally valid. Although the study sample size is not valid, this is part of internal validity, like in the conclusion is external validity is not valid. So it lacks precision and it lacks external validity. Therefore, it's not trustworthy, which is the second key. I'm hoping this is you all following me so far. So sample size justification should be reported. Yeah, the author should not simply pick a random sample size. The sample size has to be justified why they chose the specific sample size. It should be clear what methods were used to determine the sample size. Clustering should be taken into account. And lastly, if the sample size justification isn't given or restriction make it difficult to reach the desired sample size, then this should be declared. Yeah, this is very important. Or we have some restriction that prevent us from reaching a sample size, or there's some justification or why the sample size isn't reached, or why the specific way we sample the population is not ideal. This should be clearly stated. I.e., you should not discover this on your own. The author should tell you very clearly what happened. If you have to discover it on your own, then of course this is a problem. Question 4: what was the target reference population? Was the target question population clearly defined? Is it clear who the research was about? So we want to know the target or reference population is overall. We want to know who specifically is this population. When doing a cross-sectional study, a target population is the overall population you are undertaking the study to make conclusions about. i.e., this is the population at risk of acquiring the condition being investigated. So this is all the population you think can get the disease. So everyone in the population who can get the disease is your target population. Then you take a sample out of this target population. So you have to define your target population precisely, and you have to then define your sampling technique precisely. It is important that this is understood both by the researcher and the reader. So it has to be clear what the target population is. If it is not clearly defined, so even if the researcher has a very clearly defined target population, but he did not disclose it or did not explain it well enough in the research, this knocks off points. So the study is less trustworthy. If it's not clearly defined, then inferences made by the researcher may be, So was the sample frame taken from an appropriate population base so that it closely represents the target reference population under investigation? So was the sampling frame taken from the population? You take a sample from the study population, which is your target population. The sampling frame is the list of sources of the study population that the researcher has used when trying to recruit participants to the study. For example, if you want to research the frequency, the association between falling down and LDL level, for example, in an elderly population, and your sample frame is elderly patient above the age of 60 who are residing in geriatric facilities or in care facilities. Your sample would be inherently biased because this sample does not represent all the elderly participants who are out and about. If you want to do the same study and you take instead of the elderly population, takes hospitalized elderly patient, even more biased. If you take instead elderly people who are subscribed to a certain gym in your area, again your sample would be biased in the opposite direction. They would be healthier than even in even the same LDL level, they'll have less risk of fall because they'll have compounding variable. So it's important not just simply to define the population, where you take your sample from, the sampling frame, the sources of your study population has to be well defined, and it has to represent the target population. It is important that the sampling frame is representative of the target population, as the results from the study are going to be used to make assumption about the target population. Again, this is the same point. You cannot generalize the health of elderly people in hospitals to all elderly people. And a real example from real life that I go through a lot, if you follow the literature of exercise science, you find this very big problem where a lot of the studies in research and in sports science are done on relatively untrained individuals. And when you want to give advice about muscular hypertrophy, for example, to very trained individuals or athletes, it's very easy to find positive results in untrained individuals. And this is a huge problem that we have right now with sports science. Another example is actually the opposite. When you have high-end research facilities it's easy to do research in untrained individuals. That's why a lot of research is done in untrained individuals, because they're easy to find. But high-end universities have the opposite problem. They do a lot of their research in highly trained individuals, so be professional athletes. And then when you want to generalize these results in the general population or even in the trained population, the result will not generalize well. This is actually a very important problem in sports science if you follow sports science. This recently, in the last 3 weeks, there's a famous YouTuber called Jeff Nippard, if you heard about him. He's a sports scientist, and he published research done on a trained individual and untrained individual, for example, to address a problem that have been a point of debate for the past several years of whether partial reps produce the same amount of hypertrophy or more hypertrophy than full range of motion, and he actually found no significant difference. This was a landmark study because it actually addressed both trained and untrained athlete, and importantly, it compared the same patient to himself. So the comparison was auto comparison, which is one of the best study designs because you limit other confounding variables. So this is a real issue that you can find in sport medicine, for example. So convenience sampling. Convenience sampling has to be addressed, of course, and sometimes you don't have a choice but to make convenience sampling. But in those situations, you have to declare it in your research. So convenience samplings can be carried out in some situations, are used because the participants are easy to recruit. Convenience samples generally lead to representative or biased samples, and therefore cannot be used to make assumptions about the characteristics of the population. It's very important when you have a convenient sample. It can point us in the right direction that we need to do more research in this topic. Like, it's very hard to generalize the result from a convenient sample. So convenient samples are often used for pilot or analytical studies where the need for representative samples is required. So, however, the authors should make this clear in text. This is the most important point. The authors have to disclose this. This should not be something you discover after reading their research for the third time. A census is a method where the target population and the study participant are the same. So you basically everyone. So if you want to make sense the rate of falls in elderly population admitted to geriatric hospitals above the age of 65, and you go and interview every single geriatric patient over the age of 65 in your country or in your county. So this is a census. It's obviously very good. Like, it's very hard to do when you have larger population sizes. In theory, question 5, 6, and 7 don't apply to census studies. However, even if a study is described as census, should be very clearly stated where the study participants have been recruited from, and the reader should make the decision if the study is truly a census. So again, this is not something. So the old adage goes: you have to trust but verify. In research, you have to verify everything. The study should not simply be, this study is the census. No, this study aims to study this certain phenomena in this certain population, and this is how we obtained all the data from this population. So not simply say we obtained all the data from the population. You have to see how you obtained the data from the population. A census may include all the population from the sample frame, but not all the target population. In this scenario, question 5 and 6 do need to be addressed. So again, if you have like 300 geriatric centers, for example, and you interview 200 patients, and you take every single patient in this 200 patients, you have randomly selected the centers, and then you select everyone in the center. So this would be a census, but in the specific geriatric center. So it will not include all your sample population, but it will include all your samples. Was the selection process likely to select subject participants that were representative of the target reference population under investigation? So this is very important. It's almost the same as the other questions. How the research got the sample frame to the study participant, how the researcher got from the sample frame to the participant. Again, if our sample frame is geriatric centers, how did we select specific individuals in those geriatric centers? It examines the potential for selection bias and how the researcher developed methods to deal with this. So if you have a certain selection bias, if you want to see the effect of certain sleep medication, well-being, or symptomatology, and we came and selected the patients who were awake at 6 a.m. in the morning. So our result would be biased because the patients who are awake at 6 a.m. in the morning are unlikely to be on high doses of sleep medications, and even if you control for that, they're unlikely to see a great effect of sleep medication. So we have to address our selection bias and how we select the specific patients. For question 6, we are looking in depth at how the specific study participants were selected from the sampling frame. It is important to know if there were any inclusion or exclusion criteria used. This is one of the most important things you read in your methodology. Using an inappropriate criteria can have a dramatic effect on the representation. So again, if you have some inclusion criteria or exclusion criteria that exclude patients over the age of 85, and we use this to generalize all patients over 85 will have generally more adverse effects from medication compared to younger patients. So it's important to list the inclusion and exclusion criteria, and it's important to justify them. And even if they're justified, if they produce a bias, this is still a point that you have to note in your comments when you're writing reports on a critical appraisal. The way I may have not made this clear when I started. The way you fill this list is you read the paper, you have an idea about the paper, then you read the list, then you go question by question. You simply check a tick, for example, if the criteria was justified, or a cross if it was not justified, and in either cases you write a comment. So this is simply not exist or not exist, exist or not exist, and then you write a comment. There's no selection bias, or there is a selection bias, and I think this does X, Y, Z. So you have to justify your selection. So randomization and bias. It's a very important topic that pertains to all research, not just section studies, not just medical research, even all research, where you have a selection bias can occur if every unit in the sample frame does not have an equal chance of being included in the final study. So how you solve this? Randomization. Randomization is by definition, that's literally the definition of random, when every participant has the same chance of being selected as the other. So there's no difference in chance between any other participant. Randomization is used to ensure that each participant in the sampling frame has an equal chance of being included in the study. So you have to use a randomization method, and that method has to be truly random, or at least in a mathematical sense, it's very hard to define what is random, but it has to be functionally random, at least. Yeah, there's a lot of methods that can be used to actually generalize random data. You can use random number generators. You can use random tables. You can use coin flipping if you have an actual really truly random coin, a real one. So there are several methods to generalize randomization. If the method of randomization are not used, not described, and or are not truly random, this may lead to non-representative sample being selected and hence affect the result of the study. This is very important because when you have stronger studies like randomized control trial, you have to know how they were randomized. And in randomized control trial, because it's usually in a hospital, usually in a good facility, they usually have actual real randomization. So you have patients, they give them random numbers, they double blind the experiment, so the patient doesn't know, the doctor doesn't know, and then a computer or a third party does the randomization. So you have actual real randomization. So this has to be specified and has to be well described so that we will not have any other randomization biases. More accurate to say non-representative sample biases. So you have if you have a representative sample being selected, and hence the result of the study will not be represented. There are many individual cases of bias, often out of the control of the researchers, but two very common ones are the self-selection and the healthy worker. Those are very famous. I've already discussed the self-selection, and the health worker effect is basically if you want to, for example, study the rate of disease among workers, let's say the rate of pneumoconiosis among miners, and you go to the mine and select 500 miners and you review the rate of hospitalization in the past 3 years, you might think, oh, I've selected a large sample, I've selected a random sample, this is representative, but no, where you selected the sample is from miners who are currently working. So they're less likely to be currently sick, or less likely to have a sick day, or less likely to have complication related to the disease. So this is called a healthy worker effect. And when you want to measure a negative outcome that will select the patient out of the study population, i.e. the patient, if he's unhealthy, he will not come to work. So if you want to measure a certain health-related incident in a working population, and the health situation would cause them to miss work, and you measured them, you actually went to the mine, or you went to the factory, or you went to the shipyard if you're studying asbestos or something, and you selected from the workers who are currently working, your result would be biased. And this is a very easy bias to miss because you just read selected randomly from the shipyard, and you will not think to yourself, well, where were the others who did not come to the shipyard? So this is something you have to put in the back of your mind, the health worker effect, when you're selecting for an occupational disease or an exposure disease, or even if you're studying for something like cardiovascular, the effect of cardiovascular disease on morbidity, and you take working individuals who are currently working, they obviously would have less severe symptoms than people who did not come to work. So this is an effect when selected from a place of work, or a place of study. So you have to generalize and don't close your mind. So even university students, for example, anything that would, when there's a dichotomy between attendance and not attending, depending on the variable. So whether the participant attends or does not attend the activity or the work or the studying, dependent on the variable you're measuring, which is the heart disease or the morbidity resulting from the heart disease or the pneumoconiosis. This is the variable that has some effect on their attendance. Therefore, if you just select the ones who have came to work, or the students who are attending class, you'd have a healthy worker effect. 7, were the measures undertaken to address the categories of non-responders. So some measures have to be taken to address who did not respond. So when you have non-responder in a cross-sectional study, it's a difficult area to address because cross-sectional study design is inherently limited in patient outreach because you take a snapshot of your sample. So a non-responder would be someone who does not respond either because they refuse to or cannot be contacted. And this, of course, can be a very big source of bias, as we have previously explained, or because their details cannot be documented. This can pop up in a different way, by the way. When you have, for example, if you're doing research in a rural community or a community where there's a high rate of illiteracy, you won't necessarily represent people who are illiterate would be misrepresented in the sample, and people who are literate have notoriously worse health outcomes. Whether that be because of inequality or because of they're less representative, because they have less patient advocacy, whatever the root cause of the issue is, just matter of factly, patients who are lower rates of illiteracy have worse health outcomes, and they tend to be less represented in research because they're harder to reach and harder to document. This is, of course, also seen in a lot of developed countries or countries where they have where women have no one say where women have less access, let's say, to communication, or where women are not particularly encouraged to communicate with researchers, or would be unlikely for social reasons to communicate with researchers. If we're going to get the sample size, the women who actually are agreed to participate in your study are not necessarily representative of all the women in the community. Particularly if you're discussing something that has to do with a culture of honor situation, or you have to something like to do with sexual abuse, for example, or even something like circumcision, the women that would agree to participate in your study are very unlikely to be representative of the society as a whole. So this is something you also have to keep in mind. So it's important to address non-responders, maybe if the non-responders are from a specific group, which can lead to a shift in the baseline data away from that group. This shift can lead to a result that do not represent the target population. In some situations, the sampling frame does not have a finite list or fully defined baseline population. So, for example, if you're doing, if you want to do a study on a rural population and you don't know exactly how many people live in this rural population, and you just have a sampling from specific localities in the county, you of course have very vague data here. If the researcher are using a non-defined population, this should also be declared and clearly in the material and section. 8, were the risk factors and outcome variable measured appropriate to the aims of the study. So you have to appropriately measure the risk factors, specifically that would pertain to the outcomes of the study. If inappropriate measures are used in the study, it could lead to misclassification bias, and it can be difficult to determine to what extent the study reveals are relevant to the target population. So this is the same as you're measuring something. You think you're measuring something, but you're measuring something else. This is relevant when studying stuff like obesity, for example. There's many markers of obesity and poor heart condition. And a lot of these markers are auxiliary markers. They're not real markers. And when we measure them and we correlate, like when we want to correlate the level of obesity with heart disease, and then we measure BMI. And we do this in a population that has a lot of muscular people. We're not measuring the thing we want to measure. We're not measuring the effect on obesity on heart disease. We're measuring the effect of BMI on heart disease, because BMI and obesity are not the same thing. BMI is a great statistical tool, but it's not a good individual tool. And depending on our population, this has to be addressed. A very important thing is also when measuring markers. So it's very easy to conflate disease markers with the disease itself. So you have a specific marker that raises. If you have, let's say, there's a marker called C that increases with the rate of myocyte death in ischemia, and then we have a drug. This drug reduces marker C, and we make a full, very well designed randomized control study. We measure randomly given this drug to people, and we see a decrease in marker C, and then we report that this drug reduces cardiac myocyte death, reduces morbidity and mortality. We did not report the thing we actually measured. We measured a marker. We did not actually measure the morbidity and mortality. So this is very important, and this is a very sneaky tactic of bait and switch. You have to report exactly what you measured, not the marker. So the marker can be correlated independently with the drug and with the condition it tracks. So again, if a drug decreases a marker, it does not necessarily decrease the disease that causes the marker. Where the risk factors and outcomes variables measured correctly using instruments, measurements that had been trial piloted or published. This is a very easy point to understand. You cannot just simply invent a method and conduct a large study using this method. You have to pilot it. You have to prove and validate this method compared to other methods that have been previously proven to be reliable and have been validated. So you know that your method actually produces actual real results. So you cannot just simply invent a test and then conduct a study, whatever merger was this test. So your study has to be piloted. So measurements must be able to be reproduced, and yeah, this is very important. Your measurement has to be reproduced. It has to produce identical results if measured repeatedly, and so that the measurements would be exactly the same as performed by other researchers. So you see this a huge problem with pseudoscience, because they have a lot of experience and they have very pseudoscientific people, and they talk in a lot of scientific ways, and they produce and they actually do research and report findings. But whenever a serious institute or a third party try and actually recreating this result, they always fail. And then we get into problems of funding and problems ideology and stuff. So this is a big problem. We have to actually know our message of verifying the data. It has to be repeatable. Therefore, the measures must be international or globally accepted standards where possible and appropriate. If they have been used for the first time, they must be trailed, or in cases of questionnaires, they have to be piloted before being used. Question 10, we're halfway through. It is clear what was used to determine statistical significance or the precision estimate. So again, you have to clearly say that you use what specific test you use and what specific measure, i.e. the p-value, for example, or confidence interval. The emphasis for the reader is that the statistical method, software packages used, and the statistical significance levels have to be clearly stated. So, for example, using the chi-square test calculated using R language or SPSS, and the level of significance below 0.05. It has to be reported like this in the methodology. Are clearly stated, even if the paper is just presenting descriptive statistics. This is because the interpretation of statistics can be quite difficult. Often, many different methods can be used to correctly test the sample data. Again, yeah, if you have a sample, a specific type of sample, you can use several different forms of tests to determine statistical significance. And if I use a certain test and find this data to be statistically significant, and then another person performs a different statistical test and it's not significant, it would obviously be a conflict. So you have to specify which test and why you chose this test. There is such a wide range available. Knowing that the tests are most appropriate in particular situation can be hard to assess. Yeah, usually it needs to be specialized in statistics, knowing the specific test is the most appropriate test for this data. There's an exception that the researcher has his understanding, or is this expectation that the researcher has this understanding or has at least sought statistical assistance to ensure that the correct method were being used. So either the researcher has a background in statistics, or at least he's been doing research long enough to know what he's using, and obviously we don't simply trust him. He has to actually report what test he used, or he has actually had some statistical assistance with his research. The statistical significance level is usually described as a p-value. In most cases, the p-value, which is the null hypothesis is rejected, is set at 0.05. So we have where we reject the null hypothesis is less than 0.05. The confidence interval should be detected with a p-value, should be declared with the p-value, or instead of the p-value as indication of precision of the estimates. This is usually we present a confidence interval of 95%, which means that the researcher were 95% confident that the true population value of the outcome lies between these two intervals. This is very important to understand. It doesn't mean that our value lies within. Means that if we repeatedly tested this population, 95% of the times the value measured would be in this confidence interval. It doesn't mean that we're 95% certain of our result. No, it doesn't mean that. It means that if we tested this same test, we did the same questionnaire on this same population, 95% of the time, the value would be within this confidence interval. Were the methods, including statistical methods, sufficiently described to enable them to be repeated? This is very important. So if the methods were not explained properly, or there are sections or even small pieces of information missing, it would make a great difference for the reader when interpreting the results and the discussion, as they may be unsure if the correct methods are being used. Again, if you have in your research being assessed and you just say the data is significant, or we find some correlation between two pieces of data. You do not take the specific type of correlation, like Pearson correlation, for example. How am I, as a reader, to know which type of correlation you use? Maybe use the long type. Maybe use type that can be used to model different type of data, and use the wrong type of model. So this have to be very clearly stated. Okay, the methodology is the hardest part. The rest should flow easier. Results. We have 5 questions for the results. So what are the basic data? Was the basic data adequately described? So we clearly have the number of participants, the demographic makeup of these participants, the rates of means, median, mode, all the stuff that should be reported. Does the response rate raise concerns about non-response bias? So if you have a response rate of like 100%, this is strange. They have to justify why did they get 100%. That's unusual to have a response rate of every single patient you tried and get. At the same time, if you have a response rate of like 61%, why did a full 40% of your people that you reached out to not respond to your study? So it's obviously also raises a red flag. So this stuff has to be addressed. What I mean here by needs to be addressed, I don't mean you have to contact the author and tell him why. Yeah, he has to actually write it down in his description of limitations or description of methodology. If he did not do that, then you mark it as wrong and you say in your comment it has not been well described. It makes your it makes the paper less trustworthy. If appropriate, was the information about non-responders described? Were the results internally consistent? This is the issue of internal consistency, i.e., there's 5,000 participants, and in the result it's written that 50% of them were males, and then you read now when you're going through the results and you read there were like 2,000 males. 2,000 males are not 50% of 5,000 participants. So there is a discrepancy in the numbers. This is there's also an internally consistent. Internally means when it refers to the research itself, not comparing them with other research. So they don't meet. Usually it's not something as glaring as I just mentioned, like you find smaller mistakes. And this is when making up data, it's very easy. And a lot of people, when they want to publish, they sometimes take their data, and this is where they get published. When you actually, someone knows how to undergo proper statistical analysis and actually analyzes their data, you find discrepancies. You won't find easier ones like the one I just said, but there's a lot of discrepancies that can be found using statistical methods. And it's very, 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 very sophisticated methods to detect fraud. And if in serious journals, of course, these methods are applied. Not always, sadly, like they can be applied. And where the results present for all the analysis described in the methods. You have to see the results of all the analysis done being described in the methods. So for example, if someone said, I did a regression analysis, and then for the results, you don't find any mention of the regression analysis, then why? Why have we omitted it? The results section of the paper is solely for the purpose of declaring the results, i.e., the author has no opinion. He just simply says what he found. He doesn't say his opinion or his explanation of this results. He just simply states what the results are. And no opinion should be stated in this section. This gives the reader the opportunity to examine the results unhindered by the opinion of the researcher. It's important for the reader to form their ideas of the opinions about the results before progressing to the discussion stages. Where the basic data adequately described. Basic descriptive analysis aims to summarize the data, given the detailed information about the sample and measurements taken in the study. So again, the basic data has to be described. The basic data gives an overview of the purpose of the process of the recruitment, and if the sampling methods used to recruit individuals were successful in selective a representative data. Again, this is a very obvious example would be if you want to simply represent the whole community as a whole, and your sample contains 80% males. So this is obviously a selection bias. And you can see this by reading the results. The author did not declare it. You read the result table and you find the gender distribution. And then you see like 80% of the sample was males. And the study is aiming to present the entire society. So obviously, this is a very good example of misrepresentation. Given that the general population is, of course, equally distributed. The basic data gives an, already said that. If the sampling method are unsuccessful in selecting a representative sample of the target population, those participants included in the study can often be different from the target population, as we said several times already. This leads to an inaccurate estimate of prevalence, incidence, or risk factors. Especially if the group, if you're selecting for males, for example, in the general population, and the disease itself has a propensity for more males than females or more females than males, then this can seriously affect the prevalence of the disease you'll find in the population. For example, if you're studying the prevalence of heart disease and in people over the age of 75, for example, no, 75 it equalized already. So, for example, if you're studying the prevalence of heart disease in patients age 40 to 60, males have much higher rate of heart disease in this particular age group. It later equalizes, but in this age group, men have a higher rate of prevalence. I'm talking about prevalence. I'm not talking about morbidity. Men still have worse morbidity overall, even in very old patients. Just an example. So if the sampling error significantly affects your measured the thing you want to measure, then you'd have a very skewed prevalence in your data. Does the representative rate raise concern about non-response bias? So again, the response rate has to, this is the same thing. If you have a study where you want the opinion of male and females on sexual abuse, for example, in a certain area, or about the prevalence of sexual abuse, and all your responders are males, this is obviously raises a red flag. Why are the females not responding? So you have to be aware of such things. As stated previously, it can be often difficult to deal with non-responsive when you have a cross-sectional study design. If appropriate, was information about non-responders described? This is examining if information on non-responders was available and were they comparable to those that did respond. Remember that non-response bias, of course, if the non-responders are substantially different to the rest of the population. So it's not simply because you have no responders, is that there's the difference between the responders and non-responders are something that affects the thing you're measuring. So this is where you have a problem with non-responders. Were the results internally consistent? Of course, the exploration of the basic data and ask the reader spend some time exploring the numbers given in the results. In the text, figures, and tables, you see the same numbers reported in the text, the same numbers reported in the figures, the same number. Really there. Were the results presented for all the analysis described in them? So you should check for a comprehensive description of the results. Sometimes the results from all analysis are not described. If this is noted, it will be unclear whether the researcher found no significant result or just didn't describe what was found. So this is sometimes in research called p-value fishing, where you simply test for everything under the sun. And whatever has some statistical significance, you report that, and you neglect to mention all the other association. The nature of the v-value, it has a rate of rejection of false negatives and false positives. So by definition, some of the things you find which are positive would be false positive. And if you simply just fishing, p-value fishing, so simply looking for p-values, therefore you're very likely to encounter those fish. So this is a very bad practice called p-value fishing. Sometimes the results from all this analysis are not described because they're not significant, and if the results are missing, that would expect to find, if there's some result that you'd expect to find and you find missing, there's a concern that this missing result may have not been what the researcher wanted to see, and hence the author has omitted it. So for example, if he's doing some research on the effect of a certain chemical in newborns, and he finds no association in newborns, but he also did the same study on children of school age, and he did not mention the results in school age. Why didn't he mention the result of the chemical exposure on school age children? It is also important that significant levels declared in the method is adhered to. So yeah, he cannot be statistically significant 0.01, and then another time he goes statistically significant at 0.05. Has to be consistent. As the reader, it is important to watch out for phrases tended towards significant. Yeah, those phrases, if you read something like this, not just in scientific journals, it's extremely terribly bad. Like in the media, when you say something tended towards significance, this means nothing. Significance is like black and white. It's not a gradient. Something cannot be partially significant because the significance is not a test of likelihood. It's simply significant or is not significant. There's a certain threshold in which we accept to dismiss a null hypothesis. If we cross that threshold, it's significant. If it's 0.00, if it's 0.0 50001 or 5, it's not that specific. It's treated the same as if it's 0.6. There's no such thing as tended towards significance, because the significance does not measure strength. Strength is an orthogonal category. It's a category that is not related. Strength is something and significance is something. As usual, while it's true that significant data with very strong causation tend to be very strong significance, but again, this is not a causative thing. Those two variables are orthogonal; they're not related. So again, when you find something that's tended towards significance, just sigh and move on with your life. It doesn't mean anything. It is the same as unsignificant. If these were used to pay close attention to the results. So discussion, there's two questions where we're having to ask in discussion, where the author's discussions and conclusions justified by results. Sorry, there's another point that sometimes there's a limitation to significance where we have a very small sample size. Some results where you would assume would be significant if you have a larger sample size. This is true, but still the reporting is the same. It's unsignificant or significance. You put in the limitations, or the authors should put in the limitations that we did not measure a significant value, but this might be due to the small sample size, and we have to repeat this using a larger sample size. You do not put phrases like tend towards significance. So you have to be clear on this. Sometimes the effect may be real, but again, the problem is we have a small sample size, or we were not lucky, or whatever. We solve this problem. We don't use stuff like tended towards significance. So the discussion, where the author's discussion and conclusions justified, where the limitations of the study discussed. So the discussion of a paper should summarize key results from the study objectives. It should give an overall interpretation of the results of the study, keeping in mind the limitations and the external validity. The document, the discussion section should be addressed both the significant and non-significant finding of the study. This is a humongous problem in medical research, especially in a lot of different fields, but especially in medical research. Journals tend to not publish non-significant results, so people tend to not discuss them. And this really, really is bad. So you have to discuss both the significant and non-significant findings, and you have to make comparison with other researchers. And this is the point of extensibility, citing their sources, and using primary data as much as possible. Where the author's discussion and conclusion justified by the results. So the study may be well designed. The author may have designed a very good study. He may have selected a perfect study system. He may sample the data perfectly. He may conduct a satisfactory statistical test. He may produce very internally consistent and internally valid results, but then use this very good results to draw conclusions that are very unjustified. This is the example of measuring outcomes using markers, for example. This is the example I gave when using, for example, heart disease, and using a marker for heart disease, and a drug specifically reduces the marker, but does not reduce the heart disease. So if the author concluded in the study that this specific marker reduced, this specific drug reduced heart disease while he only measured the marker, this is unjustified, even if his study was done perfectly. So does the study results say the author think they say? And this is where it is important to use your judgment. And this is something you develop by reading research over and over again, and by critically appraising your research. Even if you don't do it formally, even if you're not critically appraising your research in a formal setting, every time you read the research, you should try to apply the things we talked about today, even like in a cursory matter. It's important that the reader considers the study as a whole when reading the research, even if the research or conclusions are more definitive than the study suggests. It can be that indication the researcher has misunderstood their own study, or has other motive or interest for coming to that conclusion. And again, you see this with supplements all the time. You see this with a lot of things all the time. People will draw wild conclusions from improving in markers that are not necessarily improving in health outcomes. To help assess this, the following points should be taken into account. Aim, in the discussion section, the researcher should discuss the result that pertain to the overall aim of the study, even if they're not significant. So if the aim of the study is to measure a certain thing, even if you find insignificant results, you should still discuss that. You have to address selection bias, where there's an expectation that the researcher discusses the selection bias and takes this into account when interpreting the results. It has to give a clear view of whether the researcher has a full understanding of the study design. He has to address the non-response. Were there any interpretation of the result that include the non-response, i.e. had the non-responders significantly affected the results? This is particularly important if the response rate was low. So because the non-responder may be a specific group that led to a shift in the baseline data. Is there any confounding variable? This is a major threat to the validity of practical inference made from statistical analysis about cause and effect. You know, there's a very interesting book that I highly recommend called The Book of Why by Judy Appraisal. It goes into the issue of statistical analysis. It's a popular science book, but it's highly approachable. It handles confounding really well, among other many topics. But it's a very good read that I highly suggest if you want a deeper understanding of statistics. And uses numbers. It's not as deep as a dive in as you're reading an actual statistic textbook. So confounding is actually one of the main things that led to the invention of modern statistics as we know it today. It's a major threat to the validity of practical inference made from statistical analysis about the cause and effect. Confounding occurs when the outcome of interest is associated with two independent variables, and one of those variables is closely associated with the outcome, only because it's closely associated with the other variable confounded. The research should consider. There's a very interesting story here about smoking, but I don't want to drag this for too long. So if you want to research it, search the position of Pearson, the guy who invented a lot of modern statistics, the Pearson correlation, for example. He was actually a very staunch supporter of smoking because he thought that this is a confounding variable. And he was technically statistically right, although he missed the causation in the whole situation. But this is a good story. Search for it if you want. The researcher should consider confounding in both the analysis and interpretation of the results. Non-significant results. Discussing the non-significant result is as important as discussing the significant result and should also be included in the discussion, especially if they have direct associations with the aim being investigated. If there's only small differences between the groups, non-significant results may be apparent because the sample size is too small. Again, we've mentioned this effect. It is important that the researcher has a clear understanding of this and conveys this in the discussion. The researcher it's clear that the researcher understands that the difference he sees in his sample may be due to the small sample size. And question 19, were the limitations of the study discussed? So unfortunately, all forms of research have some limitations, cross-section studies especially so. The question here is whether the researcher has an understanding of the limitations involved in their study design. If the issue is not explored, this is the cause of concern, and that the limitation does not stop at the design, and that the researcher has a poor understanding of the study as a whole. So if there's an issue, a glaring issue like any one of the dozens we've discussed today that the research did not actually address in his limitations, this is an indication that the researcher may, let's not assume malice, just when we can assume incompetence, simply does not understand what he wants to research. So maybe he just forgot to mention it or something like it. This is a bad sign if there's a glaring error that was not discussed in the limitation section. So lastly, the two last questions, were any funding sources or conflicts of interest that may affect the author's interpretation of the results? And were there ethical approval or consent of the author? This is very straightforward. If the funding sources have to be declared, and especially if they have special interest groups, it is very important that the conflicts of interest or bodies involved in funding the study are declared. Example of bias resulted from conflict of interest, where studies are funded by a specific agency, the research may unconsciously interpret in the favor of this agency's ideals. Again, a very awesome book called Bad Science, I think, by Ben Gold something. It tells the story of the whole scientific ordeal when that happened with cigarettes and it's happening today with climate change from a statistical reporting point of view. It's a great read. I highly recommend it. It goes into this point very deeply. If the researcher has worked in a specific area, their own ideas and beliefs may affect the interpretation of the results. This may be subconsciously. The researcher may not even intend to be malicious. It is up to the reader to identify this and come to the conclusion as to whether this complex or complex was there ethical approval of consent? Of course, it has to have informed consent. It's a very detailed thing that the patient has to actually know what their consent to, has to inform consent, and of course, you have ethical approval from committees or depending on where you're performing your research or where you're conducting a specific study. It's important that these are solved before carrying out research on animals. This concludes our discussion. Hopefully, I did not take too long. I know this is a very big topic, relatively speaking. Some additional resources. There's a very great series on YouTube by the Cochrane Mental Health Institute. It's called the Critical Appraisal Modules. It discusses specifically how to apply and actually gives you papers, and you can do them yourself. You can appraise this papers, and then you can see how they appraise the papers, and you can compare your work. It's like 5 or 6 videos. They go through systemic reviews, randomized control trial, cohort studies, case control studies, even cross-sectional studies. It's a very good video series. You can find it if you search for critical appraisal modules or Cochrane Health, or this is the link you can somehow copy. Any comments or questions?
No, thank you. That was very informative.
Sure.
Yeah, thank you so much, Dr. Emad. I just have one point. Do you have the screening questions table on a separate document? It would be great if you can share it in the chat box or anywhere. So that would be great. Thank you so much.
Okay. Sir, I'll share the shorts. Anybody has any other comments or?
Any questions for any of the presenters? Thank you so much, Dr. Emad, for the detailed presentation. It was great and very important for all of us. Thank you.
Yeah, I'm gonna share it to you.
And if we don't have any more questions, that concludes our today's presentations. We had one more topic scheduled, but was rescheduled by the presenter. So we were done with our presentations. So I would just go ahead and give it to Dr. Nadir if you don't have. Okay, go ahead, please.
If I shared, it's a technical question. If I shared after we close the session, will it be shared in the same chat, or can I share it now? The presentation.
Yeah, you can share it now, or you can also share it in the telegeriatrics WhatsApp group. Everybody can get it there as well.
Okay.
Is that it?
Yes.
Okay, thank you so much. And I would like to thank everybody. Thank you, Dr. Nadir, for giving us this great opportunity to present our topics. Thank you all the presenters for detailed and well-informative presentations. And thank you all for joining today. And thank you so much and have a good weekend. Thank you.
Thank you, everyone, and great presentations. Thank you so much. Any updates before we conclude, or Dr. Samahir, go ahead.
No, I just wanted to ask the same question. If there is any update or if there is anyone could share their experiences with this with their interview, because I know this is the season and people now receiving their interviews. So I wanted to know, like, if one could interested to share us.
No, that's fine. So Dr. Mohammed, if you want also, you can use the app to upload your file. So if you go to the main page, you go down, and if you scroll down, you will find files, and you can just add the files.
في الوجود أي حتة.
Okay. Thanks, Dr. Nader. I'll upload it in the app also.
Appreciate. Thank you so much.
Hello, good afternoon, Dr. Nader. I
Good
just
afternoon.
had a question
Yes.
for everyone. It's not like actually an update. It was just a general question regarding, I think everyone is aware that Tennessee state has become the first state to allow, I think, international medical graduates to work on a temporary transitional permit. It was in the news, so I just wanted to know if anybody has any information or any experience regarding it, like how to go about it, because I'll be moving to Tennessee hopefully this next month. If anyone can share any information, that'd be great.
So I don't have enough information about Tennessee specifically, but I know there are a few states, one of them Tennessee, Minnesota, I think Arizona, and
Arizona.
Washington State. These are the four that I know, or five, that they offer. Anyone else? Samahir, you want to add?
I think Arizona, yeah, and the same Arizona and Tennessee. I've heard some part from New England also. They're trying to pass this law, but it looks like in Arizona it didn't pass yet. They just make the project and it did not pass yet.
Yeah, so I have some experience on this license because I'm personally working as a post-acute care physician under this limited physician license in Washington State. So it's basically our state who just the IMG group in our state. It's our group who just pushed to just pass this bill and in our state. So it's practical in Washington State, but the criteria here is you have to just be a resident of Washington State for 1 year to apply for the license and pass all the step exams. And then after that, you can just get the license and work under supervision in any organization that's willing to hire you. And there's also another new license in Virginia that's going to be a new license. It's already they have already approved it and they're giving the license, I think, but you should have a job offer from a CGME accredited program that's different in Virginia, but it's approved there too. But about Tennessee, I have read a new news just last month that the bill was passed months before, but the medical association is not willing to process the license yet. So that was the update I have about Tennessee. But if that's the case, it's going to be great because they consider residencies from other countries like for IMGs, and that would be even more useful for IMGs. But that was the update I read last month. So this is the information I have. Thank you.
Okay, thank you. Yes, Dr. Lama. I think Tennessee also required to have either a home country residency or 3 years of work experience. It could be either US or your home country. So I think there are a few exceptions varying by state. But this was great information I got to know. So thank you.
Okay.
Thank you so much for the great question and all the answers. Thanks. Any other questions, updates, suggestions, comments? Any final comments, Dr. Samahir and Dr. Lema? Please go ahead.
Thanks so much, Dr. Nadir. I don't have anything to add, and I don't know if there are any ideas to add on. I don't have any more updates. Thank you.
Thank you very much, Dr. Nadir, for this opportunity. And I really enjoyed the presentations of all the people today, especially I like all the AI stuff and anything related to AI. And really, regarding the adult abuse, this topic, as I mentioned, it became very famous topic and one of the most testful questions nowadays at USMLE. So it's kind of very important and I really enjoyed it. Thank you.
Thank you so much, both of you, and thank you for your team to present all these great topics. Thank you for attending, for all fellows who attending today's meeting, and those who will come later. Dr. Mazir, go ahead.
Yeah, thank you, Dr. Nadir. I have just one question. I'm applying this year for residency, and I was looking for an active group doing project. Actually, I don't have any experience in publication, and you know, publication has become very important during this season and previous seasons. And I was looking for any group who is working in project, so I could work with them and join the team.
Sounds good. So the easiest way is to contact people who are working on mobile application. I think that's the easiest way to start or participate in one of the ongoing projects. There are different groups that are working on submitting or working on like abstracts or papers. So in the big WhatsApp group, you can see if there are available spots. Usually we ask them to limit the number of authors if it's an abstract to 10 or less, because when they submit their abstract, there are limited number of authors. But otherwise, there is no limitation. But the easiest approach is to contact maybe Dr. Amel Al-Amin or some of the people who are working on mobile applications. So you can join. I think there are some working on renal application and other mobile apps. So if you are interested, you can participate in these groups. There are different ways to do that. So when you approach them, they can see what your skills and what your availability, and then they can assign you to do some task, and then you can write this or talk about this experience when you have interviews or in your application or CV.
Okay, sounds good. Thank you, Doctor.
Thank you. No more questions. I'd like to thank you all, and we'll see you next week. If you have any comments or questions, please feel free to contact me, text me, email me. I'll be happy to be in contact with you guys. Thank you again, all of you, and have a wonderful day.
Thanks so much, Dr. Nadir.
Thank you so
Thank you,
much,
Dr. Nadir.
Thank you.
Thank you. Thank you so much.